Good morning. Today I will present you slides on pulmonary hypertension. Pulmonary hypertension is a disorder that may involve multiple clinical conditions and may be associated with a variety of cardiovascular and respiratory diseases. The complexity of managing pulmonary hypertension requires a multifaceted, holistic, and multidisciplinary approach, with active involvement of patients with pulmonary hypertension in partnership with clinicians. Pulmonary hypertension is a major global health issue. All age groups are affected. Present estimates suggest a pulmonary hypertension prevalence about 1% of the global population. Due to the presence of cardiac and pulmonary causes of pulmonary hypertension, prevalence is high in individuals aged more than 65 years. Globally, left heart disease is a leading cause of pulmonary hypertension. Lung disease, especially chronic obstructive pulmonary diseases, is the second most common cause. Pulmonary hypertension is defined by a mean pulmonary artery pressure, which at rest should be more than 20 millimeters, and previous guidelines it was more than 25 millimeters. In case of right heart catheterization measurement, additionally pulmonary artery wedge pressure should be estimated, and pulmonary hypertension can be subclassified as pre-capillary pulmonary hypertension if wedge pressure less than 15 millimeters, or post-capillary pulmonary hypertension when wedge pressure more than 15 millimeters. The structure of the classification is based on the 2022 European Society Cardiology European Respiratory Society guidelines for the diagnosis and treatment, and the 6th World Symposium on Pulmonary Hypertension. The general purpose of the clinical classification of pulmonary hypertension remains to categorize clinical conditions associated with pulmonary hypertension based on similar pathophysiological mechanisms, clinical presentation, hemodynamics characteristics, and therapeutic management. There are 5 groups of pulmonary hypertension. First, pulmonary arterial hypertension. Second, pulmonary hypertension associated with left heart disease. The third, pulmonary hypertension associated with lung disease. The fourth, pulmonary hypertension associated with pulmonary artery obstructions, and the 5th group of pulmonary hypertension is hypertension with unclear and or multifactorial mechanisms. So, group 1, pulmonary arterial hypertension. It's a rare form of pulmonary hypertension. Recent registry data from economically developed countries indicate a pulmonary arterial hypertension incidence and prevalence is about 6 and 50 cases per million adults respectively. It has been thought to predominantly affect younger individuals, mostly females. This is currently true for heritable pulmonary arterial hypertension, which affects twice as many females as males. In most pulmonary arterial hypertension registries, idiopathic pulmonary hypertension was the most common subtype, about 50% of all causes of pulmonary arterial hypertension, which followed by pulmonary arterial hypertension associated with connective tissue disease, congenital heart disease, and portal hypertension. Other types of group 1 may be pulmonary hypertension associated with drugs and toxins, HIV infection associated pulmonary hypertension, and other. Group 2, pulmonary hypertension associated with left heart disease. Very common, the most common form of pulmonary hypertension. In 2013, the Global Burden of Disease study reported more than 60 million cases of heart failure worldwide, which represented almost a doubling since 1990. In Europe and the United States, more than 80% of patients with heart failure are aged more than 65 years. Post-capillary pulmonary hypertension, either isolated or combined with pre-capillary component, is a frequent complication mainly in heart failure with preserved ejection fraction, affected at least 50% of these patients. The prevalence of pulmonary hypertension increases with severity of left side valvular diseases, and pulmonary hypertension can be found in 60 of patients with severe symptomatic mitral valve disease and in up to 50% of those with symptomatic aortic stenosis. Group 3, pulmonary hypertension associated with lung disease and or hypoxia. This is a common form of pulmonary hypertension. About 50% of patients with pulmonary hypertension have association with lung disease. Mild pulmonary hypertension is common in advanced parenchymal and interstitial lung disease. Studies have reported about from 1 to 5% of patients with advanced COPD with chronic respiratory failure or candidates of lung volume reduction surgery or lung transplantation. They have a mean pulmonary arterial pressure more than 40 millimeters. In idiopathic pulmonary fibrosis, and mean pulmonary arterial pressure was more than 25 millimeters. It has been reported in 10% of patients upon initial workup, with greater prevalence in advanced and end-stage diseases. The fourth group is pulmonary hypertension associated with chronic pulmonary artery obstruction. The number of patients diagnosed with chronic thromboembolic pulmonary hypertension is increasing, probably due to a deeper understanding of the disease and more active screening for this condition in patients who remain dyspneic after pulmonary embolism or who have risk factors for developing chronic thromboembolic pulmonary hypertension. Real prevalence is unknown. Registry data indicate chronic thromboembolic pulmonary hypertension incidence is about from 2 to 6%, and prevalence varies from 26 to 38 cases per million adults. Patients with chronic thromboembolic pulmonary disease without pulmonary hypertension still represent a small proportion of the patients referred to chronic thromboembolic pulmonary hypertension centers. And the fifth group of pulmonary hypertension, hypertension with unclear and or multifactorial mechanisms. This is a rare form of pulmonary hypertension. Group 5 pulmonary hypertension consists of complex group of disorders that are associated with pulmonary hypertension. The cause is often multifactorial and can be secondary to increased pre- and post-capillary pressure, as well as direct effects on pulmonary vasculature. The incidence and prevalence of pulmonary hypertension in most of these disorders are unknown. However, high-quality registries have recently enabled estimation of pulmonary hypertension prevalence in adult patients with sarcoidosis. Studies suggest that pulmonary hypertension can be common, and its presence is often associated with increased morbidity and mortality. Evaluation. The diagnostic approach to pulmonary hypertension is mainly focused on two tasks. First, diagnosis of pulmonary hypertension. Second, to identify underlying diseases, especially left heart diseases group 2 of pulmonary hypertension and lung diseases group 3 of pulmonary hypertension, as well as comorbidities, to ensure proper classification, risk assessment, and treatment. Symptoms of pulmonary hypertension are mainly linked to right ventricle dysfunction and typically associated with exercise in the earlier course of the disease. The cardinal symptoms is dyspnea on progressive minor exertion. Other common symptoms are related to the stages and severity of the diseases. All the symptoms may be fatigue, palpitations, weight gain due to fluid retention, syncope. Rare symptoms due to pulmonary arterial dilation may be hoarseness, dysphonia, shortness of breath, wheezing, cough, respiratory tract infection. Potential clinical signs and physical findings are central, peripheral or mixed cyanosis, edema, peripheral edema, hepatomegaly, ascites. Importantly, the physical examination may also be the key to identify the underlying cause of pulmonary hypertension. For example, digital clubbing may be helped to diagnose fibrotic lung disease, bronchiectasis, crackles or wheezing at auscultation can help to diagnose lung or heart diseases. ECG abnormalities may raise suspicion of pulmonary hypertension, deliver prognostic information, and detect arrhythmias and signs of left heart diseases. In adults with clinical suspicion of pulmonary hypertension, for example, unexplained dyspnea on exertion, right axis deviation has a high prevalence predictive value for pulmonary hypertension. A normal ECG does not exclude the presence of pulmonary hypertension, but a normal ECG is a combination with normal biomarkers such as NT-proBNP, is associated with a lower likelihood of pulmonary hypertension in patients referred for suspected pulmonary hypertension or at risk of pulmonary hypertension. ECG findings may be P. pulmonary, right or sagittal axis deviation, right ventricle hypertrophy, right bundle branch block, right ventricle strain pattern, prolonged QT interval. At ECG you can see P. pulmonary, right bundle branch block, right ventricle strain pattern with ST depression, T-wave inversion in the right precordial and inferior leads. Chest radiography, chest X-ray, presents abnormal findings in most patients with pulmonary hypertension. However, a normal chest X-ray does not exclude pulmonary hypertension. Radiographic signs of pulmonary hypertension include a characteristic configuration of the cardiac form due to right heart, right atrium and pulmonary artery enlargement, sometimes with running of the peripheral vessels. In addition, signs of the underlying cause of pulmonary hypertension, such as left heart disease or lung disease, may be found. You can see posterior anterior at the left panel and lateral at the right panel chest radiograph, showing enlarged pulmonary arteries. You can see black arrows, and pruning of the distal pulmonary vessels, white arrows, commonly seen with advanced pulmonary arterial hypertension. Pulmonary function tests and analysis of arterial blood gas. Very important analysis which can help to distinguish between pulmonary hypertension groups, assessed comorbidities, and the need for supplementary oxygen, and determine disease severity. For example, you can see diffusing capacity for carbon monoxide, which may be decreased at patients with primary pulmonary hypertension. Echocardiography. This method provides comprehensive information on right and left heart morphology. Also, right ventricle and left ventricle function, valvular abnormalities can be detected and gives estimates of hemodynamic parameters. Echocardiography is also a valuable tool with which to detect the cause of suspected or confirmed pulmonary hypertension, particularly with respect to pulmonary hypertension associated with left heart disease or congenital heart disease. A comprehensive echocardiography evaluation for suspected pulmonary hypertension includes estimating the systolic pulmonary arterial pressure and detecting additional signs suggestive of pulmonary hypertension, aiming at assigning an echocardiographic level of probability of pulmonary hypertension. Some echocardiographic findings of pulmonary hypertension, including estimating pressure and signs of right ventricular overload on the dysfunction, you can see at this slide. A very important parameter is a peak tricuspid regurgitation velocity. This parameter helps to estimate the diagnosis. In case of peak tricuspid regurgitation velocity more than 3.4 and presence other echo signs, patients has high probability of pulmonary hypertension. For example, at panel left is a representative echocardiogram showing the apical four-chamber view from a patient with pulmonary hypertension, demonstrating an enlarged right atrium and ventricle with some compression of the left side of the heart. At the right panel is the same echocardiographic view showing a normal echocardiogram. Ventilation perfusion lung scan is recommended in the diagnostic workup of patients with suspected or newly diagnosed pulmonary hypertension to rule out or detect signs of most of all chronic thromboembolic pulmonary hypertension. Review of a patient with confirmed pulmonary vena occlusive disease and non-matched perfusion defects. At right panel, you can see ventilation perfusion lung scan with multiple non-matched perfusion defects. Right superior lobe, right basal pyramid, common and left inferior lobe. At B and C panels, multiple histological samples from the same patient. Computed tomography or CT imaging may provide important information for patients with unexplained dyspnea or suspected confirmed pulmonary hypertension. The CT signs suggesting the presence of pulmonary hypertension include an enlarged pulmonary artery diameter, pulmonary artery to aorta ratio more than 0.9, and enlarged right heart chambers. Computed tomography pulmonary angiography is mainly used to detect direct or indirect signs of chronic thromboembolic pulmonary hypertension, such as filling defects, including thrombus adhering to the vascular wall, webs or bands in the pulmonary arteries. Representative computed tomographic scan of the chest demonstrating enlarged main pulmonary arteries. This is also a mosaic pattern evident in both lungs. At this slide, CT angiography of patient with thromboembolic occlusion of pulmonary artery, left main and right arteries. Cardiac magnetic resonance imaging. It may accurately and reproducibly assesses atrial and ventricle size, morphology and function. As additional methods of evaluation, it can be also useful for patients with pulmonary hypertension. The initial diagnostic assessment of patients with newly diagnosed pulmonary hypertension aims to identify comorbidities and possible causes or complications of pulmonary hypertension. Laboratory tests that should be obtained at the time of pulmonary hypertension diagnosis include some of tests such as blood counts, serum electrolytes, kidney function, liver parameters, iron status, NT-proBNP analysis. In addition, serological studies should include testing for hepatitis viruses and HIV. Basic immunology laboratory workup is recommended. Screening for biological markers of antiphospholipid syndrome is recommended in patients with chronic thromboembolic pulmonary hypertension. Pulmonary hypertension can be associated with thyroid function disorders, hence laboratory screening should include at least thyroid-stimulating hormone. An abdominal ultrasound examination should be part of the comprehensive diagnostic workup of patients with newly diagnosed pulmonary hypertension, particularly in liver diseases suspected. A major objective is to search for liver disease and portal hypertension or portocaval shunt. During the course of the disease, patients with pulmonary hypertension may develop secondary organ dysfunction, mainly affecting the liver and kidney. In these patients, abdominal ultrasound is needed to differential diagnostic reasons and to assess the extent of organ damage. In slide, you can see aberrant malformation is a congenital arterial defect that can lead to pulmonary hypertension. Very important slide. Right heart catheterization is a gold standard for diagnosing and classifying pulmonary hypertension. Performing this method requires expertise and meticulous methodology following standardized protocols. In addition to diagnosing and classifying pulmonary hypertension, clinical indications include hemodynamic assessment of heart. Patient has catheterization of right atrium, right ventricle, pulmonary artery, measurement of pulmonary artery pressure, wedge pressure, all basic and principal parameters for complete assessment of cardiopulmonary hemodynamics are listed on this slide. They must be measured and calculated. So, diagnostic algorithm includes 3 steps. Steps 1, suspicion. Step 2, detection, and the 3rd step, confirmation of diagnosis of pulmonary hypertension. Patients with pulmonary hypertension are likely to be seen by first-line physician, general practitioner. They have non-specific symptoms. Initial evaluation. Step 1, evaluation should include a comprehensive medical history, physical examination, blood test to determine and resting ECG. This first step may raise a suspicion of cardiorespiratory disorder causing the symptom. It was first step. The second step includes classical non-invasive lung and cardio testing. Among those tests, echocardiography is an important step in the diagnostic algorithm as it assigns a level of probability of pulmonary hypertension, irrespective of the cause. Echocardiography. In addition, it is an important step in identifying other cardiac disorders. Based on this initial assessment, if causes other than pulmonary hypertension are identified, and in case of low probability of pulmonary hypertension, patient should be managed accordingly. Step 3. Patient should be referred to pulmonary hypertension center for future evaluation. The Pulmonary Hypertension Center is responsible for performing an invasive assessment, right heart catheterization most of all, according to the clinical scenario. At any time, warning signs must be recognized as they are associated with worse outcomes and warrant immediate intervention. While pulmonary hypertension is not an uncommon condition, severe forms of pulmonary hypertension, especially pulmonary arterial hypertension and chronic thromboembolic pulmonary hypertension, require highly specialized management. Since medical center with multidisciplinary teams and a high volume of patients generally offer best standard of care, which translates into better clinical outcomes, establishing pulmonary hypertension centers is clinically and economically highly desirable and is supported by patient organizations and scientific societies. The purpose of Pulmonary Hypertension Center is to receive new referrals, assess and investigate the cause of pulmonary hypertension, carefully phenotype and routinely manage patients with medical, interventional and surgical approaches, work closely with other healthcare providers to achieve the best outcomes of patients, and be involved in clinical and translational research and education. Requirements are comprising definition, multidisciplinary structure, number of cases, procedures, and staffing levels, as well as the skills and resources needed in pulmonary hypertension referral center. Now, treatment. Treatment depends on etiology, pulmonary hypertension group, comorbidity. It differs at different forms, groups of pulmonary hypertension. Treatment of pulmonary arterial hypertension group 1 include general measures. First, supervised exercise training is recommended in patients with pulmonary arterial hypertension. Psychological support in patients with pulmonary arterial hypertension. Very important, immunization of patients against SARS, influenza, streptococcus pneumonia. Diuretic treatment is recommended in patients with pulmonary arterial hypertension with signs of right ventricle failure and fluid retention. Long-term oxygen therapy is recommended in patients with pulmonary hypertension and hypoxemia. In the presence of iron deficiency, anemia, correction of iron status is recommended in patients with pulmonary arterial hypertension. Pulmonary arterial hypertension group 1 with patients may be treated with specific therapy for pulmonary hypertension, but specific therapy for pulmonary hypertension should be initiated after comprehensive investigation at pulmonary hypertension center. Very important. Only at pulmonary hypertension center. These patients need to be diagnosed, and they need to have confirmation of diagnosis, risk estimation, initiation of therapy, and then follow-up. There are several groups of medications, drugs for specific therapy of pulmonary hypertension. The therapy may include several classes of medications, such as cerebral guanylyl cyclase stimulator, riociguat, phosphodiesterase 5 inhibitors, such as sildenafil, tadalafil, endothelin receptor antagonist, such as bazentan, ambrisentan, prostacyclin derivative, epoprostenol, iloprost, teprostenil, selective IP receptor agonist, such as selexipag. Calcium channel blockers also may be recommended at some types of pulmonary hypertension. However, combination with other pulmonary hypertension drugs should be approved again at pulmonary hypertension center. Pulmonary hypertension associated with left heart disease. Treatment of the underlying condition, heart failure most of all, is recommended before considering assessment of suspected pulmonary hypertension. It may be patient with reduced ejection fraction, mildly reduced ejection fraction, preserved ejection fraction, valve diseases. All modern up-to-date drugs for heart failure should be admitted. Pulmonary hypertension frequently occurs as a consequence of valvular heart disease. So, surgical or interventional approaches for valvular repair to improve cardiopulmonary hemodynamics, reducing wedge pressure and pulmonary arterial pressure may be needed. Now, treatment of pulmonary hypertension associated with left heart diseases. Pulmonary hypertension associated with lung diseases, group 3. In patients with lung diseases and suspected pulmonary hypertension, it is recommended to optimize treatment of the underlying lung condition. In patients with lung disease and suspected severe pulmonary hypertension, there is uncertainty regarding the treatment of pulmonary hypertension. Referral to the pulmonary hypertension center for a complete diagnostic workup is recommended, and initiation of specific for pulmonary hypertension treatment. It is recommended to refer eligible patients with lung diseases and pulmonary hypertension for lung transplantation. Chronic thromboembolic pulmonary hypertension group 4. General measures recommended for pulmonary arterial hypertension also apply to chronic thromboembolic pulmonary hypertension, including supervised exercise training, which is effective and safe in inoperable chronic thromboembolic pulmonary hypertension patients. Lifelong therapeutic doses of anticoagulation are recommended in all patients with chronic thromboembolic pulmonary hypertension. Pulmonary endarterectomy is recommended as a treatment of choice for patients with this type of pulmonary hypertension and fibrotic obstruction within pulmonary arteries accessible for surgery. Balloon pulmonary angioplasty is recommended in patients who are technically inoperable or have residual pulmonary hypertension after endarterectomy and distal obstructions amenable to balloon angioplasty. Drug therapy such as riociguat is recommended for symptomatic patients with type pulmonary hypertension or persistent recurrent pulmonary hypertension after surgery. Surgical endarterectomy is a treatment of choice for patients with accessible pulmonary arterial lesions. As surgery may normalize pulmonary hemodynamics and functional capacity, an expert multidisciplinary team, including an experienced surgeon, is mandatory for evaluating operability and deciding final treatment. Balloon pulmonary angioplasty has become an established treatment for selected patients with inoperable chronic thromboembolic pulmonary hypertension or present recurrent pulmonary hypertension after surgery, with methods improving hemodynamics, right heart function, and exercise capacity. But long-term outcomes are promising, but evidence is still scarce. Pulmonary hypertension centers should inform patients about patient associations and encourage them to join such groups. Patients associations are a valuable resource for managing patients, as they provide educational and emotional support and can have positive effects on coping, confidence, and outlook. It is recommended that pulmonary hypertension centers collaborate with patients to improve the patient's experience, addressing issues such as healthy literacy, digital skills, healthy lifestyles, mental health, and self-management. Healthcare can be delivered more effectively and efficiently if patients are full partners in this process. Thank you for attention.